From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Welcome to listeners from around the world, and thank you for tuning in to this JAMA Clinical Review podcast. I'm your host, Mary McDermott, Deputy Editor of JAMA, and I'm here today with Jennifer Brudno, Associate Research Physician of the Surgery Branch of the National Cancer Institute. She is an author of a JAMA Translational Science review on the topic of CAR T cell therapy. Welcome, Dr. Brudno, and thank you so much for joining us.
Thank you so much for having me. I appreciate it.
Let's get started. I wonder if you could tell us about what are CAR T cells and how does CAR T cell therapy for cancer work?
Sure, of course. So CAR T cells, these are T lymphocytes most often, and in the case of the commercially available products, they're the patient's own autologous T lymphocytes. These T lymphocytes have been genetically engineered to express a CAR protein, and CAR stands for chimeric antigen receptor. This is a synthetic protein that the T cells have been permanently genetically modified to express. It has extracellular components, which are meant to recognize a surface antigen, which is the target of the therapy. And this antigen is expressed uniformly on the malignant cell, which is being targeted by the CAR T cell therapy. There are also intracellular components, a T cell activation domain and a co-stimulatory domain. And the job of those components is to activate the CAR T cell when it comes into contact with the target antigen expressed by the cancer cell. So as a result, when the CAR T cell comes into contact with a malignant cell, which is expressing the target antigen, the T cell then is triggered to kill the malignant cancer cell.
And how effective are they?
It varies for what malignancy is being treated and the CAR T cell product. But we do know that for B-cell malignancies, such as B-cell acute lymphoblastic leukemia and diffuse large B-cell lymphoma, these two B-cell malignancies express the B-cell marker CD19 very well. And so the CAR T-cell products that are directed against CD19 can have efficacy in these malignancies. We know that diffuse large B-cell lymphoma and acute lymphoblastic leukemia are curable in some cases, in some percentage of patients using our traditional cytotoxic cell-killing chemotherapies. And with CAR T-cell therapy, even in cases where patients their malignancy really does not respond to chemotherapy, we know that CAR T-cell immunotherapy can come in and treat the malignancy. So we historically think of those two cancers as curable, and there does seem to be a subset of patients who are not cured with chemotherapy, stem cell transplant, these sorts of therapies, but then come in later and get CAR T-cell therapy. For diffuse large B-cell lymphoma, for example, with the axi-cell product or axicabtagene ciloleucel, about 30% of patients have long-term remissions at the 5-year mark. So many of those patients are probably cured, and a little less than half of patients with pediatric young adult acute lymphoblastic leukemia have relapse-free remissions at around the 3-year mark. So we know a subset of those patients are likely being cured. And with other B-cell malignancies, it appears that we can have very high response rates, even up to the 80s, 90s range of those malignancies. And for multiple myeloma, where there are two CAR T-cell products that target B-cell maturation antigen or BCMA, we know that the response rates can be in the 70s to 90s range.
Can you, just for our listeners, repeat what are the two cancers that are most responsive to the CAR T-cell therapy?
Oh, I apologize. I wouldn't say most responsive. I'd say that we know that these B-cell malignancies can historically be cured with chemotherapy. And these patients who are not cured with their upfront chemotherapy, it does appear that there's a subset of patients who are still cured with CAR T-cell therapy. So curable hematologic malignancies, those two curable hematologic malignancies appear to be curable with CAR T-cell therapy.
Okay, thank you. And can you talk to us about how the process actually works? Like, what do you do to the patient?
Absolutely. So the patient's cells are collected by a process called leukapheresis, which we tell patients who are about to have CAR T cell therapy that it's very similar to the process of a blood transfusion. You can do it with a peripheral IV or with a temporarily placed central line. So the T cells are collected and then they're processed ex vivo. So that usually means that the cells are then shipped to a central manufacturing facility and then genetically engineered into CAR T cells there. This is usually done with a viral vector, gamma retroviral or lentiviral vector, which is introduced into the cell culture. And then the T cells are grown into larger numbers and usually shipped back from the manufacturing facility to the treatment facility of the patient. In the meantime, the patient gets chemotherapy. This can be many variations on this theme, but most commonly is cyclophosphamide and fludarabine. Chemotherapy, which is meant to prime the immune system so that the CAR T cells can be more active when they're infused into the patient. So after a few days, often as few as 3 days of conditioning chemotherapy, the CAR T cells are infused into the patient and actually proliferate in the patient's body. So a larger number of CAR T cells result after several days of being introduced back into the patient.
And how often is this typically repeated?
That's a great question. It's often very much considered sort of a one and done therapy, with having subsequent infusions at a later time having kind of variable efficacy. But that's something that patients really like. You have one infusion of the cells, which can have side effects and, of course, can be inconvenient because often this therapy is given in an inpatient hospital setting. But after that, patients are monitored off therapy, and if they achieve a remission, are essentially monitored in remission until time of relapse, if that occurs.
And is this a therapy that most hospitals in the United States have? Is it something you have to go to an academic medical center to get?
It's more something that a patient would have to be referred to an academic medical center, which is certainly a disadvantage of the therapy. Increasingly, with some of the commercially available CAR T cell products, there's increasing comfort with doing some outpatient administration and admitting patients if they have side effects from the CAR T cell therapy. But that would shorten the overall admission time if you're not admitting every single patient up front. But despite that, this is still very much something that is done at larger academic centers. And it does mean that in many cases, patients have to travel to academic centers to receive this therapy.
And earlier you referred to, you kind of said, well, a subset of people might get cured for some cancers. But can you give us a sense, like, what proportion of people who get the therapy have some level of benefit from it?
Oh, sure. So we would say anti-malignancy response, right? So that means a substantial shrinkage in the tumor burden or substantial elimination from the bone marrow of the malignancy. So for, let's say, diffuse large B-cell lymphoma, there are 3 commercially available CAR T-cell products, and it's fairly consistent response rates, 60s to 80s. That's patients getting partial and complete remission, and then complete remission rates in the 50s or so, especially for lysocell and axicell. So that's diffuse large B-cell lymphoma. For other lymphoma subtypes, follicular lymphoma, mantle cell lymphoma, the response rates can be higher, even in the 80s to 90s range, with the majority of patients really having some kind of anti-malignancy benefit to the CAR T-cell therapy. With CLL, it tends to be on the lower range, like say about 40 percentile range. And then with acute lymphoblastic leukemia, there is a relapse rate, which is fairly substantial, but on the order of 80s to 90s% of patients, even up into the 90s% of patients can have elimination of ALL from their bone marrow. With multiple myeloma, with the 2 commercially available CAR T-cell products, response rates in the 70s type range for ide-cel and then the high 90s for cilta-cel.
Talk about the adverse effects, please. What are the common ones and how common are they?
Adverse effects include cytokine release syndrome, which is often referred to as CRS. That is very common and happens in the majority of cases, but is often mild. That is a syndrome of fevers, tachycardia, hypoxia, hypotension, although not all of those symptoms may exist at the same time, and the patient may have just mild fevers. On the more severe end, the patient could require intensive care because of deep hypotension requiring vasopressors or hypoxia or respiratory compromise that would require, at the more severe end, mechanical ventilation, which is not common, but certainly has been reported with both the anti-CD19 and the anti-BCMA CAR T-cell products. This is considered a toxicity that patients have usually just in the first couple weeks and then is resolved. Additionally, common toxicities are neurologic toxicities. This is especially true for the anti-CD19 CAR T-cell therapies that can include confusion, somnolence, dysphasias, and then on the more severe side, motor difficulties. Cerebral edema is very uncommon, but has been reported. So very similar to cytokine release syndrome, there's a wide range of neurologic toxicities in terms of how they present and then also in terms of their severity. And these are also toxicities that occur in the first couple of weeks after the CAR T-cell infusion. And I should mention briefly that for anti-BCMA CAR T-cells, there are also Parkinsonian syndromes that have been reported that are not very well understood and are uncommon, happening less than 5% of the time, but certainly are reported and can happen weeks to months after the CAR T-cell infusions. Those are much more delayed and are sort of in their own separate subcategory of neurologic toxicities.
And the FDA, I think earlier this year, released some information that perhaps these therapies can cause secondary malignancy. Can you comment on that?
Yes. So that's a great point. I'll say that there are two separate issues to talk about there. So on the one side, I'll talk about the more common thing first. There is secondary myeloid malignancies, such as myelodysplastic syndrome and acute myeloid leukemia. These things, unfortunately, are very common in patients who have hematologic malignancies that have required multiple chemotherapy regimens and potentially autologous stem cell transplant. And they certainly have been reported in the population of patients who have had CAR T-cell therapy for the hematologic malignancies. Not surprisingly, because many of those patients who have CAR T-cell therapy have already had many prior chemotherapy regimens. So it's not known to what extent the CAR T-cell therapy increases risk for secondary myeloid malignancies, or if it is something that increases risk. And this is something that is being still actively researched to determine how much of a risk it is, but certainly it's well reported in the CAR T-cell population, as it is in the population of patients that have had many prior chemotherapies for their hematologic malignancy. The second issue is T-cell malignancies. T-cell malignancies appear to be very uncommon after CAR T-cell therapy. Earlier at the end of 2023, there was a report that there were 22 new T-cell malignancies out of 27,000 treatments with CAR T-cells. So that's clearly a very rare event. But there is concern that in some small number of cases, those T-cell malignancies appear to express the CAR protein. So it's not clear to what extent the CAR T-cell process, the having one's cells taken out, processed, and put back in, and having the post-inflammatory syndromes, how much that really contributes to the development of a T-cell malignancy. In many of these cases, the patients already had a T-cell clone, like a precursor to the T-cell malignancy, even before they were treated with CAR T-cell therapy. So the causal link is also not entirely established here. But regardless, it's a very rare event, but it's an important event for physicians to be aware of and to discuss with the patients they're treating.
Sure. How durable are the benefits of these therapies?
So again, it depends on the malignancy. For multiple myeloma, we say that we still can't say that CAR T-cell therapy cures multiple myeloma. We still consider multiple myeloma an incurable malignancy, though centers that have treated a lot of patients with anti-BCMA CAR T-cell therapy are starting to see patients that are maintaining their remissions 3, 4, 5 years, even further out. So certainly with anti-BCMA CAR T-cell therapy, durability is possible, but it's unknown if it's curative. Again, we can, I think, pretty safely say at this point that large B-cell lymphoma and ALL, there is curative potential, but in less than half of the total number of patients that received the CAR T-cell therapy in both of those cases. And then for follicular lymphoma, mantle cell lymphoma, CLL, we do see that there's a little bit of a plateau on the progression-free survival curve. So there are patients that are maintaining their remissions years out, certainly quite a few patients at 1, 2, 3 years, and then even beyond, but it gets to the point where the data become a little bit early for those further time points.
Now, your review in JAMA talks about some of the logistical challenges associated with getting the therapy into patients, and I wondered if you could comment on that for our listeners.
Right. So this is very much a tailored therapy. It uses the patient's own T cells, and then they have to be manufactured centrally. So that means it takes time to genetically engineer the T cells and to grow the T cells. So that means that there is a wait time, which can be anywhere from about 2 weeks to about 2 months, a wait time in between collecting the cells and then the patient receiving the cell infusion. So that is potentially problematic in patients for whom traditional therapies such as chemotherapy really are not effective because the malignancy could progress and become life-threatening or could make the patient very ill such that the CAR T-cell therapy would be very difficult to tolerate in terms of the side effects. So with certain malignancies, time is definitely not on your side. And so we don't want to have long wait times. So that unfortunately continues to be an issue. Additionally, CAR T-cell therapy is very expensive. The cell infusion itself can cost in the hundreds of thousands of dollars. And so in terms of a broader healthcare system model, it's, very difficult in terms of making sure that all patients have access to this type of therapy.
Can you tell us about what new discoveries are underway and what can we expect in the coming years with regard to this type of therapy?
Absolutely. There are a lot of exciting things that we talk about in the review. One thing to mention is that in the past year, there have been 2 cellular therapies FDA approved for solid tumor malignancies, which are not CAR T-cell therapies, but are also adoptive immunotherapy. One is lifileucel. This is a tumor-infiltrating lymphocyte therapy, or TIL therapy, which is now approved for advanced melanoma, previously treated advanced melanoma. And the other one is afamitristgene autoleucel, which is a TCR T-cell therapy. So it is also genetically engineered, but with a synthetic T-cell receptor instead of a CAR receptor. And that's now approved for advanced synovial sarcoma. And the response rates for those cellular therapies are in the 30s type range, but there already is clear data that there's durability for some patients. So that's very exciting because both of those patients have previously treated metastatic melanoma and previously treated synovial sarcoma. They have really very few treatment options. So should a subset of those patients have a durable remission, that's really beneficial to these patients.
I'm Mary McDermott, and I've been speaking today with Dr. Jennifer Brudno about CAR T-cell therapy for cancer. Dr. Brudno is co-author of a JAMA Translational Science review on the topic of CAR T-cell therapy that was recently published in JAMA. You can find a link to the article in this episode's description. For more of our podcasts, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.